Hello and welcome to the quick revision program for this INI-CET examination in orthopedics. I am Dr. Yusuf Tyagi, your mentor for orthopedics in Allen's. You see, in order to keep it very simplified, what we have tried is to pick up the questions and the topics which were asked previously, like from November 2018 up to November 2022. Out of all the questions which were asked, like orthopedics was asked around 60. So 60 questions were asked in total. Around 58 to 60 questions were directly linked to orthopedics. You know, the total topics out of which all those questions were asked for the last 3.5 or to 4 years were just 10. And if you look at about the specific topics, then those specific topics are just around 25. That means उन 25 topics में से ही all the questions are getting accumulated and they are creating all the questions out of those 25 topics itself. So एक छोटी सी analysis like what we have done in order to make the process easier for you. All right. अब इसमें what are those topics and how the questions are going to be formulated? This is what we are about to do in this revision class, obviously. So as you came to know that the total number of topics, like for every year there are around 8 to 9 questions on an average which are asked out of orthopedics. अब वो 25 ही topics हैं जिसमें से 8 to 9 questions are getting created. All right, they are creating or formulating the questions out of those topics only. So this is what the basis of our revision class is. अब उसमें कौन-कौन से topics हैं, means what are the common topics out of which these questions are being asked. Like first is what you see in the emergency. Like you know that as a doctor, as a resident medical officer, if you are there in the emergency, then how to make the process painless for the patient. That is point number 1. Second, one question always from the nerve injuries, and in front of you we are having the topics which are asked out of these nerve injuries. Very simple. You just have to understand that how these things are getting converted into topic, right? Or question. Then the tumor, at least one question out of tumor every time, and not all the tumors. You know, for INI-CET in particular, they are asking the questions out of GCT and osteosarcoma. Then the complications of the fractures. You know, one of the most dreadful complication of the fracture obviously is the compartment syndrome, and they are asking this question, compartment syndrome, continuously. Then from the pediatric orthopedics, since recently they have started asking the questions on congenital talipes equinovarus. Since 2017, they have asked the question related to the Sprengel shoulders, all right? And we also expect that they will ask a question related to a hidden condition that needed to be screened in order to make the diagnosis, and that is developmental dysplasia of hip, all right? Then as far as the spine is concerned, you all know that ankylosing spondylitis is considered to be the favorite topic, although we have covered it when in the integrated sessions. So here we are going to concentrate on tuberculosis, the management, as far as the scoliotic deformities. One question out of metabolic disorders, one question out of, you know, eponymous fractures or the injuries which are very commonly seen, or the fractures which are just seen in the form of a one-liner, all right? Examination of hip. Now this is something. Since 2019, the examiners are more interested in asking the question out of this topic, examination of the hip. And when we are going to discuss it, you'll come to know the reason why this question is a hot favorite today. And yes, the braces associated with the diseases, they are asking about the braces too. So that was an overview of how those questions are getting asked. So segment 1 obviously is the segment of emergency. Now, you know, the one of the question which was asked in November 2022, that open fractures are best managed by. That means what is the way you are going to treat the open fracture. So then they are not asking the basics. They are simply asking what is the step that you have to follow. Another question is external fixators having highest stability. Like which of the following is external fixator would be having the highest stability? Ek aur question. Again from the emergency. Then another question which got was asked in June 2021 was that the patient came with the fractured shaft of femur with posterior displacement. All right. Then what next you have to do? Simple. Like just on the basis of what you are going to do. It is not something which is going to be mentioned in, or which will be mentioned in any of the books. All right. All of the following are the components of a skeletal traction, again a procedure of the emergency in order to immobilize the fractures, and ring sequestrum is a feature of, which was asked in November 2020. So these are your sample questions. These are the questions which were already asked. As you can see, 5 years, 5 questions out of this topic in particular. That means emergency management of a patient with trauma. So what you see in the emergency, all right? after doing the generalized survey and after assessment of the airway, breathing and circulation, then you have to identify the deformity. एक patient है जिसको fracture हुआ है, all right, there is a deformity obvious. Now because of this deformity, because of this displacement, the condition is extremely painful. So what you do, first of all, identify the deformity. Then what you try to do, you try to do the closed reduction. All right, you are not going to open the fracture at that point in the emergency itself. What you do, if there is a fracture, you just give a gentle traction so that they get reduced. If they are not completely reduced, at least they get aligned. So this alignment will help in relieving the pain of the patient, as well as it will also help in the possible impingement which it might be causing to the nerve. It might be causing impingement to the vessel, it might be causing impingement to the skin, it might be causing impingement or injury to the muscle, all right? So all these things are going to be relieved. Once the reduction is achieved, then you have to immobilize it or stabilize the fracture for the time being, temporary stabilization. Now that temporary stabilization is something which they are asking. अब यही आपसे पूछ रहे हैं उस क्वेश्चन में कि वो temporary stabilization, how to achieve it. You know, for upper limb fractures, it is just a hemi-circumferential sling application or hemi-circumferential application of a support in the form of a slab, which could be above elbow, below elbow, based upon the fracture which is there. Okay? So for upper limb, it is the slab application. But for lower limb, after reducing the fracture, after rendering the patient relatively painless, it could be either splinted by a Thomas splint, and this is how you are going to identify a Thomas splint. All right. Here, the Thomas splint is having an inner bar. The Thomas splint is having an outer bar. How to identify the outer bar? There is a angulation, and all of you know that this angulation is in order to accommodate the greater trochanter of the femur, you know, for the GT of the femur, and we are having a circle. Then, so the limb is kept immobilized in it. The limb is going to be kept immobilized like this, rough diagrammatic representation, and then the bandages are applied. So this is one way, application of a Thomas splint. And the other way is the application of a skeletal pin or a skeletal traction. And how this skeletal traction, or what are the components of this skeletal traction? This is the question which they have asked. So what are the components? First of all, before we even coming to the components, what are the indications? Means किस वजह से skeletal traction को use किया जा सकता है? What are the indications? Stabilization, that means immobilization of the fracture. Second is reduction of the dislocated joint or dislocated fracture, subluxated joint. Then maintenance of the muscle length or the length of the tendon, all right? क्योंकि fracture होने की वजह से there could be overriding, and in order to prevent this overriding, the maintenance of the length of the muscle is also important. Then correction of the deformity, all right? If there is a deformity of any joint which comes under the segment of other diseases, but yes, skeletal traction is used in order to correct it gradually. And the complications, obviously. But before we talk about the complications, let's talk about that what are the components of this skeletal traction. You see, if you concentrate on this image, this one, then here a pin is inserted, like this is the pin which is inserted over here, all right, through the bone, and it is connected by a stirrups. So what are the components? One of the component is a pin which is required, and the name of this pin is Steinmann pin. All right, Steinmann pin. Steinmann pin is the most commonly used pin for a skeletal traction application. Simple, how to identify this? This is a pin which is having one end blunt and the other end pointed. Why the other end is pointed? In order to make it go through the cortex of the bone. Second point is, apart from Steinmann pin, even Denham pin can also be used. But this Denham pin is different from Steinmann pin, that it is having a central serrations like this. We are having a central serration in order to have a better cortical purchase, all right, in between. So Denham pin is used. So Steinmann pin and Denham pin. Denham pin particularly is used for the skeletal traction application in cases of elderly. Why elderly? Because they are having weak bones. And in order to gain a better cortical purchase, there has to be a serration in the center. So this is how to identify a Steinmann and a Denham pin. Both of them are used for skeletal traction application. That is point number one. Now the second is the bowler stirrup. Now this is a pin which we have already talked about. Now the second thing is the bowler stirrup. This one. It is the bowler stirrup. All right, so these are the components. Now, although you can use a drill, but the drill is avoided because it might result in a greater kinetic injury and it might result in overheating of the bone at the point of entry. So a T-handle can also be used for this purpose. All right, so this was your question asked. This exactly was your question asked. All right, so what are the components of the skeletal traction application? Now, as far as complications are concerned, infection, obviously that if you are having something which is passing through the bone and is also exposed to the external environment, there is always a possibility of infection in long-term use. Loosening of the pin is always a possibility, and the bone through which you have entered the pin might result in blackening of the edges of that bone, and it might result in the sequester formation. All right, so these are the components of a skeletal traction application, and these are the indications. So if you go back to the questions, like whatever the questions which were asked previously, all of the following are the components of a skeletal traction application. The question which was asked in November 2021, Steinman pin, yes, it is a component. Bowler stirrup, yes, it is a component. Pulley, yes, because that ring, because that rope has to be attached to a pulley at the end of the bed. But Thomas splint is not directly used for the skeletal traction application. It is just for the mobilization of the entire limb, right? So this was the question asked in 2021 in the November session. Next, once you have managed the patient, आपके पास patient आया, आपने deformity identify करी, आपने closed reduction achieve करा. After achieving the closed reduction, you have immobilized it. But now go for the definitive management. अब उस definitive management के लिए there is a closed fracture and there is a open fracture. Obviously, if there is a open fracture, then it becomes the emergency, that it has to be treated as early as possible, all right, as soon as possible, because of the possibility of infection, because of the possibility of the bone necrosis. So you have to treat it as early as possible, stabilize it. But before stabilization, wound debridement is necessary, all right. After adequate anesthesia, you will thoroughly wash the wound. Once the wound is washed, then you go for open reduction and external fixation. Now just try to understand what is the concept behind this. एक क्वेश्चन आपसे पूछा गया था कि open fractures are best managed by, and you know it was in November 2022. उसमें the question options were like open reduction, internal fixation, closed reduction, internal fixation, likewise were the option, and the answer was open reduction, external fixation application. Why? If there is a fracture, all right, open fracture means that the fracture edges are exposed to the external environment. That means once you are stabilizing it by the placement of an external fixator, then why to attempt for the closed reduction? You can see the fracture, all right? You can fix it or you can reduce it under the appearance of your naked eyes directly. So open reduction, that means you are fixing the fracture by visualizing it, by holding it with the clamps or the bone holders. Reducing it, then fixing it, and then stabilizing. This stabilization is achieved. So open reduction, internal fixation. All right. Don't avoid looking at that fracture by performing closed reduction. There is no necessity of doing closed reductions. एक बात और, जब भी आपसे कोई नॉन स्पेसिफिकली कोई क्वेश्चन पूछा जाता है रिलेटेड टू ओपन फ्रैक्चर्स, देन दैट क्वेश्चन इज गोइंग टू बी आस्क्ड related to Gustilo-Anderson type 3 only, all right. Type 1, type 2 में क्योंकि we can go for internal fixations also. जो concept है आपका कि वो high grade open fracture injury है, non specifically if it is asked, then you have to go for external fixation application. अब एक question आया था which I already told you about, that external fixators, you all know what the external fixators are, but what is the planar system? उसमें uniplanar भी हो सकते हैं, biplanar भी हो सकते हैं, circular means circumferential भी हो सकते हैं. So this is a uniplanar external fixator, and as you can see, the biplanar external fixator is going to be providing more stability in comparison to the uniplanar one. Similarly, we have got the railroad external fixation systems, and obviously all of you are aware of this Elizarov ring external fixation system. All right, so hopefully you have understood कि ये क्वेश्चन आपसे क्यों पूछा जाता है. This question is simply asked कि आप अपना common sense use करें, and after using your common sense you just have to answer the question, which obviously does not require any protocol to be fulfilled. All right, once you have seen this patient, once you have immobilized this patient, once you have managed these patients, you would be able to mark the answers correctly very easily. Now if you go back to those questions again, all right, if you go back to those questions, like question number 1. Now now it will become much easier for you to answer this question कि open fracture को are best managed by options provided are open reduction, internal fixation and all, as we have already talked about. So simple, it is open reduction and external fixation. Alright, why are you not performing internal fixation? आप कोई ऐसा implant क्यों नहीं डाल रहे जो कि bone से directly fix कर दे उसको, because of the possibility of infection. Here you are not treating the fracture, you are just salvaging the limb, alright, so that there are less complications. So open reduction, external fixation is the answer for that question. Next is external fixators which are having the highest stability. Simple, external fixator jitna uniplanar is going to be least stable, biplanar will be more stable, but you know, it is Elizarov ring external fixation system, which is a circumferential fixation system which will providing the maximum stability to the fractured fragments, alright. Uniplanar, biplanar, hopefully you came to know about what is the concept behind this. Next is a patient came with the fracture shaft of femur with posterior displacement. अब एक patient आया आपके पास emergency में है, and what exactly immediately what you will try to do? You will try to reduce it, alright, by the gentle traction application you will try to reduce it. So simple, closed reduction and stabilization. You are not going to fix it immediately. First of all, stabilize it by performing closed reduction. Simple. This was the question asked in June 2021. Next, all of the following are the components of skeletal traction we have already talked about. Next, ring sequestrum is a complication of, you know, anything which is gaining entry into the bone in the form of a circular way. There is a possibility that it might lead the edges, it might result in the blackening of the edges, all right, and that blackening of the edges might result in the formation of the sequestra. So ring sequestrum is the feature of, answer is simple, that it is a feature of the external fixator application. Alright, this was the question asked in November 2020. So hopefully you have understood. ये segment 1 था, which we have talked about. The complications of external fixation system means, again, no need to learn or mug this thing up. It is very simple. एक infection हमेशा हो सकता है, because this is something which is gaining entry into the bone and is exposed to the external environment too. Second, ring sequestration, as I already told you about. You know, there are two conditions in which ring sequestration can be formed. One is external fixations, all right, fixators, and the second one is the amputation stump. Amputation stump. Next, loosening of the implant, secondary injuries, muscular as well as neurovascular injuries, muscular contractures and neurovascular injuries. So these are the complications. अब इन सारे complications में कौन सा ऐसा question था जो examiner पूछ सकता था आपसे? That is all about ring sequestration. He is not going to ask about infection because he knows that you can relate it with the infections of the external fixation of the application. You know, one more thing which is very commonly seen in the emergency in orthopedics is the dislocation of the hip and dislocation of the shoulder. Now, as if you are sitting in the INI-CET examination, this is not something that you might not be aware of. All right, ये कोई ऐसा topic नहीं है जो कि आप पहली बार सुन रहे होंगे, and hopefully you all of you might be aware of what exactly is the dislocation of the hip and how to identify it. You know, hip dislocations can be categorized into, although there are multiple variations, but as far as for examination purposes, it could be categorized into posterior dislocation as well as anterior dislocation of the hip. Now, posterior dislocation of the hip simply means that there is a attitude of flexion, adduction and internal rotation of the thigh or the hip. Once the hip gets dislocated posteriorly, it will result in the flexion, adduction and internal rotation of the hip. All right, in classes we have already talked about what is the reason, what are the consequences and how to reduce it. All right, this requires reduction. Then anterior dislocation of the hip, on the other hand, it is associated with flexion, abduction and external rotation, all right, of the thigh. The attitude, whenever you see a patient with the anterior dislocation of the hip joint, he would be having a flexion, abduction, external rotation deformity of the thigh, on the basis of which you will be identifying it. As far as posterior dislocation of the hip is concerned, shortening is present. Yes, there is shortening. But in case of anterior dislocation of the hip, there is no shortening. And you know the reason also. Why there is no shortening? Because the proximal migration of the head of the femur is prevented by rectus femoris muscle. And this results in no shortening, or in some cases even apparent lengthening of the limb. Alright? ये हो गया hip dislocation के identification criteria. ये पूछा जाता है आपसे. They used to ask it, although it goes more in favor of NEET PG examination. But yes, this is the question which they have asked in 2018 and got repeated in 2020. Next is the shoulder dislocation. Again, shoulder dislocation is of multiple types like anterior, posterior or inferior type. But here we are going to talk about the two most critical one, the anterior and the posterior one, on the basis of which you are going to differentiate it with. So anterior dislocation agar shoulder mein hota hai, then what is the attitude with which the patient will come? So the attitude would be the flexion, abduction and external rotation. While for the posterior dislocation of the shoulder, the arm or the shoulder is in adduction and internal rotation. So ये एक basic से differences हैं on the basis of which the examiner is asking the question again and again, and you have to identify it. Simple as that. In details we have already talked about it, but yes, this is something which you cannot leave and go. All right, आपको ये पढ़ना होगा. Associated with the posterior dislocation of the shoulder, sciatic nerve is commonly found to be injured. Sciatic nerve injury, posterior dislocation of the hip. Anterior dislocation of the hip theoretically might lead to a femoral nerve injury, but you see it is not very common. Means we have not seen a single case where there is anterior dislocation of the hip associated with a femoral nerve injury. All right, but it is a theoretical possibility. As far as shoulder dislocation is concerned, both with anterior as well as posterior, the axillary nerve is likely to get injured. All right, and this is our second segment, you know, the nerve injury. Every time you go and sit in the examination hall, you will find these questions related to nerve injury. Every time they are asking the questions related to the nerve injury, like nerve injury with intact apineurium. This is for the first time they have asked a question which is related to the classification systems of the nerve injury. All right, and the answer for this question was axonotmesis. Simple. You know, Seddon has classified the nerve injuries into 3 simple criteria: the neuropraxia, the axonotmesis and neurotmesis. And you are very well aware of the fact that neuropraxia is when the nerve has stopped conducting its nerve impulses, but there is no anatomical integrity which is broken. That means there is no anatomical injury to the nerve. That is neuropraxic injury to the nerve. And you are already aware of the examples like, you know, Saturday night palsy, the axillary crutch palsy. So these are the common, tourniquet palsy. These are the common examples associated with it. Axonotmesis is that anything inside the nerve could be injured, but the outermost layer, that is epineurium, it remains intact. All right. It could be injury to the axon. It could be injury to the perineurium, it could be injury to the endoneurium, it could be injury to the fascicle, but the outermost layer of the nerve, that is fibrous layer of the nerve, that is epineurium, it remains intact. This is axonotmesis. And neurotmesis simply is when there is a complete break of the nerve. That means even the epineurium is broken. There is a separation of the nerve. So it is an injury which is a result of a incisional injury. All right, sharp object injury. So that is neurotmesis. So this was the question asked based upon the structure of the nerve and the possible outcomes of the injury to the nerve according to the Seddon classification. Then there is a question which was asked like inability to hold the paper in between the 2 fingers in 2019. There was a question asked like if there is a injury, if there is a fracture of the proximal aspect of the fibula, then what it will result in. Then there was a question asked that all of the following are the features of the Klumpke's palsy except. All right. Then there was a so these were the questions asked. Now what all you have to remember, आपको बहुत ज़्यादा deep study means you need not to go too much into the details at this point of time for your INI-CET. What just you have to remember is related to nerve injury is एक ऐसा bone का association anatomically with that nerve, that if there is an injury to that bone, then what is the name of the nerve which is likely to get injured. That is point number 1. And second is what are the functions of those nerves. All right, like for example, if there is a shoulder, every one of you are aware that if there is an injury into the proximal humerus, then axillary nerve is going to be injured. अब वो shoulder dislocation हो, वो fracture of the proximal humerus हो, axillary nerve will be injured. And what are the features of the axillary nerve injury? Again, you are very well aware of the fact that there could be a limitation of abduction of the shoulder, there could be limitation of external rotation, there could be a limit, then there is regimental badge sign, all right, loss of deltoid contour. तो axillary nerve injury के features are also important for you to remember, क्योंकि उस पे questions formulate होते हैं. Next is if there is a fracture in the shaft of humerus. Again, this is something which you are aware. Fracture हुआ shaft of humerus में, तो radial nerve will be injured because it is directly related to the shaft of the humerus along the axis. Then अगर supracondylar fracture of the humerus है, then it is anterior interosseous nerve which is a branch of median nerve which is injured. So you should be aware of what all are the clinical features, as we are going to talk about it later. Then agar elbow dislocation hai, then ulnar nerve will be injured more commonly. Monteggia fracture dislocation, the posterior interosseous nerve, which is a pure motor branch of, it is again a branch of radial nerve. All right, in case of Monteggia fracture dislocation. Walkman ischemic contracture, anterior interosseous nerve is injured. The posterior dislocation of the hip, sciatic nerve is injured. Wrist dislocation, or if there is a compression of the wrist, median nerve is injured, which will result in carpal tunnel syndrome. So all these things, like knee dislocation is there, then the common peroneal nerve is injured. All right. अब उसमें features of axillary nerve injury, limitation. तो आपको वो जो common और important features हैं, you should also be aware of those common and important nerve injury and their features. Like axillary nerve अगर injure होती है, then what are the common findings associated with it? Limitation of arm abduction. You know, the arm abduction is going to be limited. Second is loss of deltoid contour, because deltoid is the muscle which is supplied by axillary nerve. And if there is a disuse atrophy of this deltoid, then that contour on the shoulder would be reduced. Then regimental badge sign, because this is the area, the upper lateral aspect of the arm. All right, the upper lateral aspect of the arm, this is the area which is supplied by the axillary nerve. So agar axillary nerve injury ho rahi hai, so over here there will be a loss of sensations, and this is the area where the badges for the identification of the regiments in the army are provided. So is wajah se it has been named as regimental badge sign. So kya means, this is how the questions are getting asked. Simple. Then features of radial nerve injury, all of you are aware, wrist drop will be there. All right, inability to extend the metacarpophalangeal joint will be there. Then there will be a loss of sensation over the first dorsal web space of hand. So loss of extension of elbow, wrist and MCPs, and the sensory loss over first dorsal web space of hand based on the level of nerve injury. Then the features of PIN, posterior interosseous nerve injury का क्या feature होता है? एकलौता feature, and that is loss of metacarpophalangeal joint extension only. इसमें कोई sensory loss नहीं होता. There is no sensory loss in case of PIN injury. All right. So this is something which again you are very well aware of. A radial nerve injury के features based upon the level of involvement. Above the level of a styloid process, at the level of a styloid process, below the level of a styloid process, just at the level of the elbow, and the injury to the its pure motor branch, that is posterior interosseous nerve. तो ये सारी चीज़ें भी बहुत commonly पूछी जाती हैं, and you should always be aware of this. All right. Again, I'm saying we are only talking about the very, very important topics which they have asked for the last 5 years consistently, which they are asking about it. Now comes a point. अब इन्होंने median nerve injury के ऊपर questions पूछे हैं. They have asked it. Right? They are giving you the pictures and then they are asking it. Like in this first picture, it is a pen test. Pen test. अब pen test को identify आप pen से नहीं करेंगे. Pen test को identify, you are going to identify the pen test by the movement of the thumb. That what is the movement of the thumb that is being tested over here. So the movement is abduction. You are testing abduction of the thumb. All right. And abduction of the thumb is the function of median nerve. If the patient is able to lift the thumb in abduction, that means median nerve is normal. If the patient is not able to lift it into abduction, that means median nerve is injured, and that will result in a pen test positivity. All right. So you are not going to identify the test along with this object or based on the objects. Dusra test, the pointing index. Again, pointing index, you are aware of that it is a feature of a median nerve injury where there will be a inability to extend the index finger when all the other fingers are getting flexed when they are asked to get flexed. All right. Pointing index. Then ape thumb deformity. So in case of ape thumb deformity, what happens? That the thumb is kept in adduction. Thumb is kept in adduction to the wrist. That is ape thumb deformity. And it is because of the active adductor pollicis brevis muscle. Because active adductor pollicis brevis. It is because of the active adductor pollicis brevis muscle, because adductor pollicis brevis is the only muscle, you know, which in the thenar eminence, which is not supplied by median, it is supplied by the ulnar nerve. Then we have got the Kilonavin sign. All right, this is Kilonavin sign. What is Kilonavin sign? You ask a patient to form a pinch. In case there is a circular pinch form because of the flexion of the thumb and flexion of the interphalangeal joint of the finger, it is normal. But in case the median nerve injury, the patient won't be able to make a circular kind of a pinch. So this is Kilo-Nevin sign positivity, which is again a feature of median nerve. So ye cheeze bhi means they used to ask these questions also. They will just give you a clinical picture. They might ask about the name of the muscle. They might ask about the test in particular. So that is Kilo-Nevin sign. You already know what the Kilo-Nevin sign is. Like, you know, flexion of the thumb is the function of flexor pollicis longus muscle, which is supplied by, yes, median nerve. Flexion of interphalangeal joint of the finger, this index finger is again a function of median nerve, which is achieved by flexor digitorum profundus and flexor digitorum superficialis. All right. So both of them are supplied by median nerve. Hopefully you have understood. Next are the features of ulnar nerve injury. All right. This one is the book test. Again, as I told you, that you need not to identify a test based upon the object. यहाँ पे हो गया रहा है, they are asking a patient to flex the thumb or adduct the thumb and hold the book tightly while the examiner is trying to lift the book or pull the book. So that is book test. So in book test, what is the name of the muscle that you are testing? You are testing adductor. Adductor of the thumb you are testing. And you know, adductor of the thumb is supplied by ulnar nerve. You know, the patient tries to modify it because if he is not able to hold the paper or book tightly by adduction, he will try to bring the flexion of the thumb into play, and that is known by the name of Froment sign. And now he will be able to hold the book tightly because flexion of the thumb is the function of flexor pollicis longus muscle, which is not supplied by ulnar, it is supplied by the median nerve. All right. So the patient would be able to hold the paper or hold the book tightly now. So that is the modification of the book test. Then card test. Now in card test, which is again a feature of ulnar nerve injury, what is the name of the muscle that you are testing? Is the palmar interossei. And you know, this palmar interossei is again supplied by the ulnar nerve. Hopefully you have understood that this is also supplied by the ulnar nerve. Then we are having this claw hand. Although this is a complete claw, but all of you are aware that claw hand is a feature of ulnar nerve injury. And because majority of the lumbricals are supplied by the ulnar nerve, so more or less a complete kind of a claw can happen in case of median and ulnar nerve injury. So this claw hand is also a possibility, is also a feature of ulnar nerve. And how to identify a claw hand? Flexion of interphalangeal and extension of the metacarpophalangeal joint. And then this is EGAVA test. EGAVA test for the ulnar nerve injury. Here you are testing the dorsal interossei. And you are aware of the fact that dorsal interossei as well as palmar interossei, all of them are supplied by ulnar nerve. All right. So this is what they are asking about the ulnar nerve injury repeatedly. So how they are asking the question? उन्होंने दिया there was a fracture of the lateral end of the lateral epicondyle of the humerus. कब fracture हुआ? And it went into the cubitus valgus deformity. Progressively it went into a cubitus valgus deformity. Because of this cubitus valgus, what happens that the ulnar nerve is getting compressed as a cubital tunnel syndrome. All right. And the features of the ulnar nerve injury at this point is going to be all those features that we have already discussed. अब यहाँ पर उन्होंने पूछा that the patient is not able to hold the card after getting fracture over the lateral condyle of the humerus. What is the name of the nerve that is likely to get injured? So this is how they are asking the questions. All right. Simple, same topics, but they are just modifying the language of the questions. Then the features of Klumpke's palsy, you know, Erb's palsy, Klumpke palsy, these are two kind of the things which are very likely to be kept in your examination. It was kept in November 2022, Klumpke palsy. That the feature of Klumpke palsy are Horner syndrome. Yes. Claw hand, you already are aware. Thoracic outlet syndrome. Basically, thoracic outlet syndrome is the compression of, C8 and T1. All right. Thoracic outlet syndrome hota kya hai? It's a compression of C8 and T1. And what is Klumpke's palsy? It is the C8 T1 compression. Why? Because it is the compression of the lower trunk of the brachial plexus. ये भी आपको मालूम है. It is the compression of the lower trunk of brachial plexus. And what are the features of the compression of the lower trunk of the brachial plexus? One is Horner syndrome. You remember Horner syndrome? Meiosis, anhydrosis, loss of ciliospinal reflex, then ptosis, that means drooping of the eyelid. So these are the features of the Horner syndrome. Claw hand, you already are aware. It is an intrinsic minus deformity. Why is it? It is also known as intrinsic minus deformity, the claw hand. All right. And this claw hand is because of the abduction of the external rotation and Sorry. I'm really sorry. I have to put this. This is some bell which is kept over here, and I don't know how it started functioning. I have to keep it out. All right. We'll be back in a second. All right. I'm sorry. So what we were talking about were the features of the Klumpke's palsy, and you know the claw hand is the extension of the metacarpophalangeal joint and flexion of the interphalangeal joint. Then we have got this thoracic outlet syndrome where there is a compression of C8 and T1. All right. So it is a feature of a thoracic outlet syndrome. Klumpke palsy related question was asked very recently. Then we have got another question like Erb's palsy. And you know, Erb's palsy related questions are very common or likely to be asked in your examination. The reason is very simple, that it is a very common phenomena where the upper trunk of the brachial plexus might get stretched, and it leads to the adduction and internal rotation of the arm, and it might result in pronation of the forearm, all right, with the extension of the elbow. So these are the clinical features. These are the clinical features of the Erb's palsy. And what happens in Erb's palsy? It is the injury to the upper trunk of the brachial plexus. Upper trunk of the brachial plexus. Why? Because if the child is at the time of delivery, if the shoulder gets stuck under the pubis of the mother, then by untrained eye, they used to pull this child out, and there might be a tractional injury to the upper trunk of the brachial plexus. This is a very common phenomena. It is observed. And the name of the deformity is also known by the name of policeman tip deformity. This is something which you are aware of. All right. So at least one question out of these nerve injury kind of the questions, like features of common peroneal nerve injury, they are asking it. Very common. Again and again they are asking it. Like inability to dorsiflex the ankle because tibialis anterior is the muscle. Tibialis anterior is the muscle which might get paralyzed. Then inability to extend the great toe, which is again supplied by the deep branch of the deep peroneal nerve. That is extensor hallucis longus. All right. Loss of sensations over the first dorsal web space of foot. These are the features of the common peroneal nerve injury, and a high stepping gait. All of you know high stepping gait, because if the foot is in plantar flexion, then in order to perform the normal gait, he has to take a higher step in order to have a greater clearance of the ground. All right. So this is high stepping gait, which is again a feature of a common peroneal nerve injury. So these all are the features of the common peroneal nerve injury that you have to remember. All right. So if you go back to the questions like which were asked previously, like all of the following are the features of Klumpke palsy. Now you will be able to answer it very easily. Like meiosis, yes, it is a feature. Loss of ciliospinal reflex, yes, it is a feature. Pen test obviously is not a feature. Claw hand is a feature. All right. So of the Klumpke's palsy. Next, fracture is given to you. Over here we are having a fracture. So then what it will result in? So fracture is there in the proximal aspect of the fibula. And you know the name of the nerve which is lying very closely approximated to the fracture proximal aspect of the fibula and then runs down is the common peroneal nerve. So it might result in the common peroneal nerve injury. And once you have identified a nerve injury, you should also be aware of the outcomes of this nerve injury, that what it will lead to. So this is what exactly the examiners are trying to ask. Although this image is not correct, it should have been a cubitus valgus deformity if they are asking about it. But inability to hold the paper between two fingers of the same hand after the nerve injury is obviously the ulnar nerve injury. All right. So you just have to Don't look at the image. This is a question which we have already discussed. So this table is also extremely important, and the outcomes of the nerve injury, the common one. You don't have to remember the outcomes of uncommon type of the nerve injury. These are the common ones which you have to remember, because they are asking a question out of these ones only. All right. So that was segment 2. First segment was the emergency related questions. Segment 2 was the nerve injury related question. And out of the previous examination, every time we have got the question out of these ones. Next are the tumors. You know, I don't know the reason, means the reason is still not clear, but every time you get a question related to a tumor, most likely they will ask about the giant cell tumor. I don't know what are the reasons behind. So at least these are the facts that you have to remember about the GCT. First of all, identification, that how you are going to identify a GCT or a giant cell tumor. Simple. You just have to see a lesion and locate it. If it is epiphyseal, yes, there is a possibility that it is a GCT. But before confirming it, you have to see that there is no growth plate visibility in that particular bone. There is no growth plate visibility. That means it is the X-ray of a skeletally mature individual where the growth plate is already obliterated, and this gives, or this goes in the favor of the giant cell tumor. All right. So it is an aggressive benign tumor. This is something which you are already aware of. It can metastasize even as a benign tumor. It can metastasize. Yes, the distal radial tumors, it can metastasize, or distal radial GCT can metastasize to lungs. All right. This is one such exception. ये एक ऐसा benign tumor है जो metastasize भी कर सकता है. All right. Distal radial GCT. Then it can turn malignant. Yes, there is always a possibility that GCT can go into a malignancy. One is osteosarcoma. ये भी question they used to ask. One is osteosarcoma. Second is fibrosarcoma. And the third one is malignant fibrous histiocytoma. All right. So these are the questions in which the GCT can be converted into. These are the tumors, malignant tumors in which GCT could be converted. Next, epiphyseal tumor in adult. This is what we have already told. It is rarely metaphyseal, but that too in case of a child, because in case of a child, what happens? It could be a metaphysio-epiphyseal kind of a tumor. All right. So it is epiphyseal tumor. It's not, it doesn't mean that it is a metaphyseal tumor. Metaphysio-epiphyseal, and that too in case of a child, and that too is a rare phenomena. All right. अब आते हैं इसके मैनेजमेंट पे. इसके मैनेजमेंट से रिलेटेड भी आर इंटरेस्टिंग फैक्ट्स दैट यू शुड बी अवेयर ऑफ. वन इज एक्सटेंडेड क्यूरेचर. ऑब्वियसली मेन स्टे ऑफ द मैनेजमेंट फॉर जीसीटी इज द सर्जिकल मैनेजमेंट. सर्जिकल मैनेजमेंट में क्या करेंगे आप? एक्सटेंडेड, यू गो फॉर एक्सटेंडेड क्यूरेटाज, यू गो फॉर द एब्लेशन ऑफ द मार्जिन्स, जिसमें की पॉसिबिलिटी रिकरेंस की कम हो जाए. देन यू हैव टू गो फॉर द ग्राफ्टिंग, यू कैन गो फॉर सीमेंटेशन, इवन गो फॉर द फिक्सेशन बेस्ड अपॉन द लोकेशन, बेस्ड अपॉन द साइज ऑफ द लेजन, बेस्ड अपॉन द यूज ऑफ द पार्ट ऑफ दैट लिम्ब. ऑलराइट, ये हो गया इसका मीन. सर्जिकल मैनेजमेंट इज द मेन स्टे ऑफ द मैनेजमेंट फॉर जीसीटी. बट यू नो, ओनली ड्रग विच इज रिकमेंडेड टुडे, only drug which is recommended today in the management of GCT is denosumab. All right. So by subcutaneous injections of denosumab, 120 milligram is the dose given in 4 weeks duration up to the duration of 6 months with a loading dose in between, is considered to be the only drug for the management of GCT. But this drug is not the cure for GCT. You know, the possibility of recurrence is too high. उसके पीछे भी reasons हैं, but you need not to go too much into the reasonings. But yes, denosumab is the drug which is the only drug used in case of GCT as far as management. It is the only drug approved by FDA. Then, although it is considered to be radio resistant, GCT एक radio resistant tumor है, but in order where it cannot be excised, means for some locations like if it is there in the vertebral column, all right, where it cannot be completely excised, then you have to go for the radiotherapy where it is unresectable, or in case of recurrent tumors. But although radiotherapy has got limited role in the management of GCT. So interesting point. Yes, we are expecting this thing to be already asked, or means they can also ask these kind of the questions in future, all right, related to radiotherapy management. As far as osteosarcoma is concerned, things which you are already aware of, like 20 years of age, that means 10 to 20 years of age, males are very commonly affected in osteosarcoma. It is the tumor of osteoid origin. All right, this is the tumor where there is an osteoid matrix origin, and this is one such tumor. Osteosarcoma is a kind of a tumor which is metaphyseal. All right, so it's a metaphyseal tumor. All right. Now, Now comes the important part. What are the association? One of the association is retinoblastoma. You are already aware. Second association is the Thomson syndrome because of the same gene, that is P53, and the Lee-Fraumeni syndrome. So there is a possibility that they might ask about the syndromes which are found to be associated with osteosarcoma. एक बात. दूसरा, causes of secondary osteosarcoma. You see, this is a very important table which we are expecting to be asked very, very commonly. पिछले कई मतलब although they are asking questions out of osteosarcoma, but they are not touching this topic, that what are the causes for secondary osteosarcoma. We are expecting this question. Paget disease, most importantly, you have to remember. Radiation induced fibrous dysplasia, osteochondroma, chronic osteomyelitis, even the GCT can go for the osteosarcomatous changes, bone infarcts, osteogenesis imperfecta. But we are expecting, if at all they are asking this question or they are going to ask this question, then it would be based on the Paget disease. All right, ये वो conditions हैं which can be converted into osteosarcomatous lesions in future also. All right, so this is a possibility that they might ask this question. Then comes the fourth segment, and the fourth segment is that of the compartment syndrome. You know, compartment syndrome से related questions पूछे जाते हैं, like they have asked this question in 2020 November session, like what is the last sign of compartment syndrome? All right. Then they have asked about that what next will you do in case of a patient who is likely to have a compartment syndrome. So what you all need to remember under this heading of compartment syndrome, the first one is the etiology. You know, there could be intrinsic or there could be extrinsic compression. All right, extrinsic compression. Intrinsic compression means if there is a fracture, like if there कोई fracture हुआ है, कोई injury हुई है, limb injury, all right, then it will result in intrinsic compression because of the collection of too much of the blood inside. Extrinsic compression means if there is a cast or if there is a, अगर आपने कोई plaster लगाया हुआ है उसके अंदर, if there is a slab application, then it will result in extrinsic compression. तो compartment syndrome का जो basic rule है, you have to relieve the compression in the management process. All right, जो clinical features हैं, so it will lead to pain, it will lead to swelling, it will lead to limitation of movement, there will be extensive swelling, and there will be pain on passive stretch of finger in case of upper limb, toes in case of lower limb compartment syndrome. All right, so most important clinical feature goes pain on passive stretch, pain on passive stretch of fingers or toes. So this is considered to be a key term in the identification of a compartment syndrome related question. Then the management अगर intrinsic compression है, then you have to go for fasciotomy. But that fasciotomy has to be processed as early as possible. That means within 6 hours of injury. If there is a time which is beyond 6 hours of injury which has gone, then it might result in the vicious changes. In those cases, the management of the compartment syndrome by performing a fasciotomy would have altered outcome. All right. So in order to prevent it, it has to be done as early as possible. That means within 6 hours of injury. Now the indications of the fasciotomy, you know, what is the exact indication? तो कंपार्टमेंट सिंड्रोम की डेफिनेशन मींस डायग्नोज कैसे करें कंपार्टमेंट सिंड्रोम को. सो वन ऑफ द इंडिकेशन विच इज कंसिडर्ड टू बी द बेस्ट इंडिकेशन एंड दैट इज क्लिनिकल सस्पिशन. ऑलराइट, that you have to means there has to be a clinical suspicion that you have to perform a fasciotomy. Second is a theoretical indication, and that theoretical indication is that if the difference between mean arterial pressure and compartment pressure is less than 40 millimeters of Hg. All right, you measure the mean arterial pressure of the patient and you measure the intercompartmental pressure of that compartment, and the difference is found to be less than 40 millimeters of Hg, then it becomes a theoretical indication to perform fasciotomy. Lekin highly less likely that in case of INI-CET, they are going to ask you about the best indication possible, and that is clinical suspicion. All right, you don't follow this theory every time. That is just for the bookish purposes. आपको जब आपका पास patient होगा who might be suffering from the compartment syndrome, then based on your clinical suspicion, you are going to perform the fasciotomy. अब आते हैं common sense related questions पे. Like the question which was asked, एक patient है who had a fracture both bones of the leg, was admitted for surgery with the above elbow slab application. Third day on round, professor noted a swelling on toes and extension of the toes. On extending the toes, patient experienced intense pain. तो ये क्वेश्चन है that on the basis of which you can say that patient might be landing up in compartment syndrome. Now what next? What next will you do? Will you waste time in measuring the intracompartmental pressure? Obviously not, because this is the time to take up the action, and that action would be based upon the management protocol. Perform close reduction internal fixation? No, because limb salvage has to be done. Fracture reduction could be delayed. Fasciotomy, obviously, you see, you are not aware. 3 दिन हो गए patient को लेटे हुए, means the patient is admitted for the last 3 days. So you are not exactly aware that there is a dislocation. There is is it for the last 6 hours which this thing is happening, or for the last 1 day? You are not aware. So fasciotomy at this point of time is dependent on multiple factors. But yes, at least you have to remove the slab and start appropriate drugs immediately, as early as possible or as soon as possible. So this is the thing which you have to remember about it. All right. So ये हो गए common sense related question. Until and unless you don't know about the topic, it is highly unlikely that you might go with the answer correctly. Then comes about the Shubham, you are asking pain which is not being relieved on giving painkillers. I'm sorry, I don't understand your question. All right. So first deformity which is getting corrected in CTEV. All right. What is the name of the first deformity that gets corrected in CTEV? That is a question which was asked in November 2022. Again. So they have asked a question related to CTEV. Next is timing of first cast application in CTEV. You know, there were 2 frames of the question which were asked related to this, and the same 2022 this question was asked. All right. In INI-CET examination. Now there was another question which was asked related to the pediatric orthopedics, but let's have a discussion on the CTEV itself. First of all, CTEV, that is congenital, the full form is congenital talipes equinovarus. Congenital talipes equinovarus. अब ये condition से related आपको 3 points. There are only 3 points that you need to remember. Point number 1, identification. That how will you identify a CTEV foot? Point number 2 are the deformities, and point number 3, what is the management? So first of all, identification of the deformities. CTEV means since birth the patient is having a plantarly flexed foot that is known as equinus. All right. So what is equinus? It is the plantarly flexed foot, but it is considered to be the most resistant deformity. जब आप इसको treat करने जाते हैं, then equinus is the most resistant deformity to get corrected. Second is inversion of the foot. All of you know what the inversion and eversion of the foot is. Second is inversion. And the third one is forefoot adduction. You know, if you divide the foot into forefoot, midfoot and hindfoot, that anterior most aspect of the foot is in inverted. So that is inversion. It is the most recurrent deformity. The CTEV most recurrent deformity is the inversion, the forefoot adduction. Then is the varus, which is combination of the deformities and the internal rotation of the tibia. So these are the principal deformity. अब आप identify कैसे करेंगे CTEV को based on the first 3 deformity. The foot is in equinus, all right. The foot is in inversion and the forefoot is adducted. So based on these 3 deformities, आप उसको identify कर लेंगे problem को that he could be suffering from CTEV. Point number 1. Second is the management. अब management के लिए in case of a newborn, what you have to remember that there are 2 methods. One is Ponseti method and the other one is Kites method. Now Ponseti method is a preferred method, while the Kites method is obsolete, sort of obsolete method. All right. क्यों है Ponseti method is preferred? Because the timing of first cast application is as early as possible in case of Ponseti method, while the timing of first cast application is 3 months after. That means 3 months of age the first cast is going to be applied by Kites method. तब तक means till the age of 3 months, mothers are asked to manipulate the foot in order to correct the deformities, all right, to get it to some extent corrected. But I will apply the first cast on 3 months. It is not having a better outcome, all right. By that time, the deformity might get more rigid. Second point is that order of correction of the deformity. You know, in case of Ponseti method, once you have corrected the cavers, or once the first cast is applied in excessive supination, and after that all the deformities are corrected simultaneously. So molding the foot and deformities are corrected simultaneously. Application of cast, repeat the cast after 1 week, repeat the cast again after 1 week. So gradually all the deformities are over corrected. All the deformities, remember. So all the deformities are corrected simultaneously according to Ponseti. But in case of Kites method, there is an order that you have to follow. First cavers, then adduction, then inversion, then equinus. So obviously, because all the deformities are directly or indirectly connected to each other, that is why it is having the inferior outcome. The treatment becomes longer and the outcomes become inferior. That is the reason why preferred method is a Ponseti method. और इस पे भी question आया था in 2022 November session. All right. So if you go back to the question was that what is the timing of first cast application in CTEV? So answer is 2 weeks of age. Out of the multiple options which were provided, 2 weeks of age is the correct answer, because Ponseti is something that you have to go with. Then the first deformity which is corrected in CTEV is the cavus deformity, which is corrected first. So hopefully you get what are the kind of the questions. CTEV पे questions क्यों पूछे जाते हैं? Means why is it expected kind of a topic? Because it is a very common abnormality which is seen on day-to-day basis. It is very, very common finding. Next, the third one is the splint. अब आपने सारी डिफॉर्मिटीज करेक्ट कर दी, देन यू हैव टू प्रिवेंट द रिकरेंस. तो स्प्लिंट का इंडिकेशन करेक्शन ऑफ द डिफॉर्मिटी नहीं है. फर्स्ट ऑफ ऑल, पॉइंट नंबर 1, दैट स्प्लिंट इज नेवर यूज टू करेक्ट द डिफॉर्मिटी. इट इज जस्ट यूज टू प्रिवेंट द रिकरेंस. सिंपल. So what are the splints which are used in case of CTEV? One is Dennis Brown splint. Already you are aware of the nomenclature. And the second one is Steenbeek foot abduction brace. This SFAB is a slight modification of the DB splint at this point of time. Highly unlikely to be asked. So you don't go too much into the details. Like in DB splint, this is how the DB splint looks like. All right. The Dennis Brown splint looks like. So ये भी एक क्वेश्चन है. CTEV से रिलेटेड क्वेश्चंस आर एक्सपेक्टेड, क्योंकि इट्स अ वेरी कॉमन फिनोमेना, इट्स अ वेरी कॉमन फाइंडिंग. इट इज कंसिडर्ड टू बी द मोस्ट कॉमन कंजेनाइटल एबनॉर्मैलिटी एनकाउंटर्ड इन ऑर्थोपेडिक प्रैक्टिस. ऑलराइट, CTEV. और क्योंकि उसका मैनेजमेंट सिंपल है, ऑल यू हैव टू डू इज अर्ली डायग्नोसिस. क्योंकि इफ इट बिकम्स रिजिड, इफ इट बिकम्स रिकरेंट, इफ इट गेट्स नेग्लेक्टेड, तो उसका मैनेजमेंट वुड बी a corrective surgery, and that corrective surgery requires the operative procedures obviously. So uska management will become difficult. All right, so early identification and counseling of the parents are important, और इस वजह से ही they are asking this question. Next question is a Sprengel shoulder. 2017 they have started asking this and got repeated one more about a Sprengel shoulder. What it is? It is a incomplete descent of the scapula. You know, asymmetrical scapula. Simple. So it is asymmetrical scapulae. That means incomplete descent of the scapulae. Now this incomplete descent of the scapulae will result in a high lying kind of the scapulae. अब ये क्वेश्चन आपका, there are two reasons why they are going to ask this question. पहला रीजन है based on, the first reason is obviously identification. ये आपसे क्वेश्चन इसलिए पूछा जाएगा कि आप इसको आइडेंटिफाई कैसे करो. ऑलराइट, स्प्रेंगल शोल्डर को तो आप आइडेंटिफाई करोगे बेस्ड अपॉन द एसिमेट्री ऑफ द स्कैपुला, दैट इट इज अ कंजेनाइटल प्रॉब्लम वेयर देयर इज अ इनकम्प्लीट डिसेंट ऑफ द स्कैपुला. सेकंड इज दैट व्हाट आर द एसोसिएशंस, और कौन सी कंडीशंस हो सकती हैं विद विच this Sprengel shoulder is associated. So those association, one of the association is Klippel-Feil syndrome. You know what is Klippel-Feil syndrome? It is a congenital fusion of two or more than two cervical vertebrae. Then other association could be the diastomatomyelia and structural changes in the form of, you know, anything which is directly or indirectly connected to the scapulae might result in the structural changes, like ribs could be altered, there could be a kyphoscoliotic deformity. So structural changes in the bones around. One very important finding in this Sprengel shoulder is the limitation of shoulder abduction. Why the shoulder abduction is limited? Because shoulder abduction beyond 90 degree requires external rotation of the scapulae, and because this scapulae is rotated, it is mal rotated, it is broader, there will be a limitation of external rotation, so the limitation of abduction of the shoulder will always be there. So limitation of shoulder abduction. Alright, so this is one such clinical feature which is found to be associated with Klippel-Feil syndrome. तो ये आपके वो points हैं which you have to remember about Klippel-Feil syndrome. Alright, point number 1, Sprengel shoulder. Point number 1 is the identification. Second point are the associations. So in pediatric orthopedics, at least you have to remember this one. SK, you are asking about what are the indications of surgery. You know, indications of surgery is that one is the age which is beyond 3 years of age. Alright, that is considered to be one. But although we are trying to go for the conservative method, at least up to 5 years of age in case of CTEV, Second is, if majority of the time this patient with CTEV, they comes with the neglected CTEV, ठीक है, like 20 years of age, 18 years of age, 15 years of age, जिसमें उनको लगता है कि अब इनकी शादी होने वाली है, like the patients are about to get married, and if they are having this deformity, so उसमें you have to go for surgical interventions only, all right? और those surgeries हैं, there are multiple procedures, which one is the best based upon the age, based upon the deformity, based upon the texture of the foot, उसमें there are multiple variations in the surgeries, all right? Hope you get the answer for your question. SK, you are again asking, is it not winging? Yes, very good. It is not winging of scapulae. You know, winging of scapulae means there will be a more prominence of the medial aspect of the scapulae, and both the scapulae are going to be at the same level. So this is not winging of scapulae. This is, yes, this is a springed shoulder. All right. We are also expecting this DDH, developmental dysplasia of hip, to be asked. Like, how to identify a developmental, देखिए developmental dysplasia of hip से related अगर कोई question आता है, then they are going to ask you these two particularly important topics. Point number one, what is the screening investigation for DDH? All right, that is point number one. So screening investigation for DDH is the ultrasonography. Point number two are the X-ray findings. What are the X-ray findings in the developmental dysplasia of the hip joint? अब जब बच्चा बड़ा हो जाता है, where the head of the femur as well as the acetabulum, both of them becomes both of them gets calcified so that it can be visualized on the X-ray. तो उसमें there are specific X-ray finding. If you make a line through a triradiate cartilage, if you draw a line through the outer border of the acetabulum, all right, then you can very clearly see that head of the femur on one side, the normal side, is in the inner lower compartment, while the head of the femur on the opposite side is in the upper outer quadrant. All right. So on the basis of this, you are going to identify that this is the X-ray of developmental dysplasia of hip. There are other findings also, but आपको अगर identify करने के लिए पूछा जाता है ये question, then this is the X-ray that you are going to get. All right. The third important related to the clinical findings or the clinical features of the DDH is that there will be a limitation of abduction of thigh. The thigh is going to be, there will be a limitation of abduction of the thigh in case of developmental dysplasia of the hip joint. Right. So these are the things that you have to remember at least at this point of time for this segment, this pediatric segment. So if you go back to the question, like simple questions were asked, pediatrics, orthopedics, अब ये पूछने लगे हैं. And yes, you know, we have talked about the Perthes, we have talked about the slip capitofemoral epiphysis, we have talked about rickets in particular in integrated sessions, you know. So you also have to watch those integrated sessions in order to get the idea of about these conditions that we have talked about. Next segment is that of a spine. The questions are asked related to or pertaining to tuberculosis, like they are asking about the management of tuberculosis, they are asking about the basic concepts of the tuberculosis, and they are asking everything related to scoliotic deformity. So question number one, that most common type of tuberculosis of the spine. Simple question. Paradiscal is the answer for this question. I'm not going to discuss it in this revision class. You already know the answer for this question. Next, all of the following are the surgical indications of the port spine except, all right, that all of the following are the surgical indication, which one is the exception? Milwaukee brace, what is the indication? So these were the questions. All right. So tuberculosis of the spine, what all you have to remember, point number one, are the neurological grades. अगर किसी को TB spine की हुई है, then there is always a possibility that the accumulation of the abscess, the structural changes, the spondylodiscitis, all these might result in the compression of the cord or compression of the nerves. All right. And this will have a neurological outcome. Now, those neurological outcome is divided into 4 grades. The grade 1 is where the patient receives or the patient experiences no motor loss. That is grade 1. The grade 2 is that the patient starts feeling that there is some weakness, so he walks with support. All right. Grade 3 is that the patient is not able to walk even without support, but there is associated sensory loss also. What is most important for you is the grade 4 that you have to remember. That means there is a paraplegia inflection with more than 50% of the sensory loss in the lower limbs, and with the bowel and or bladder incontinence. That means the patient won't be able to feel the defecation or urination process, so bowel and or bladder incontinence. So that is grade 4 paraplegia. So importance of knowing about these grade is that it dictates the management, it dictates the treatment. All the other three, you know, grade 1, 2 and 3 are treated conservatively. That means you will ask the patient to get this AKT started, you ask the patient to go for absolute bed rest, and you observe the patient. So conservative management. Then on observation, if there is a deterioration, then you have to open it. You have to perform the debridement, you have to decompress the nerve. But for grade 4, you have to go for surgical decompression and debridement. So actually out of 4 grades, it is only the grade 4 which requires surgical decompression. All right, on the all the other forms of the tuberculosis, first you have to go for the conservative management. Then you have to switch over to the surgical management if at all there is a requirement. So if you go back to the question, then what was the question? That all of the following are the surgical indications for the Pott's spine except, so bowel bladder incontinence, yes, it is a surgical indication. Psoas abscess, if there is a collection of the too much of the abscess in the psoas region that requires to be drained, yes, psoas abscess has to be drained. Loss of motor power, absolutely not, because it is lost in case of grade 3 also. It is lost in case of grade 2 also. All right, so loss of motor power is not the sole indication where you have to perform the surgery. And suspicion of the other diagnosis, yes also, because in that case you have to obtain a biopsy, because if you are suspecting that he could also be suffering from any other condition from tuberculosis, then in that case biopsy is required. So these are the surgical indications where these are the indications where you have to perform surgery. Other than this, ATT and bed rest is the important fact that you have to go with. Next is scoliosis. What is a scoliotic deformity? Point number 1, what you have to remember, all of you know what the scoliosis is. It is the lateral bending of the spine. All right, lateral bending of the spine or the lateral curvature of the spine. That is a scoliotic abnormality. Simple. Now, what all you need to remember under the X-rays, point number 1, the apical vertebrae. Apical vertebrae is the one which is maximally deviated and is maximally rotated. So that is apical vertebrae. Out of the entire contour, the one vertebrae which is maximally deviated from the center and is maximally rotated, obviously, so that is apical vertebrae. End vertebrae are 2, the upper end and the lower end. That means the upper end vertebrae is the one from which the scoliosis is getting started. That means minimally deviated upper end vertebrae, and we are having a lower end vertebrae. So these are end vertebrae. Now, what is the importance of these vertebrae? What is the importance of naming these vertebrae? Is to calculate the angular deformity. You know, if you draw a tangent from the upper end of the upper end vertebrae and the lower border of the lower end vertebrae, and if you drop a perpendicular in between the two, in between what you get as an angle, this angle is the Cobb angle. All right, so this angle is the Cobb angle. So answer for this question, scoliotic deformity, is the Cobb angle. So these are the things that you have to remember: apical vertebrae, the end vertebrae, the Cobb angle, and then the Risser sign. You know, Risser sign is not for diagnosis of the scoliosis. Risser sign is to predict the progression of scoliosis. Remember this fact. You know, whether the scoliotic deformity will be progressing or not based upon the fusion of the iliac bone apophysis is Risser sign. So these are the facts, 4 facts that you have to remember about the Cobb angle or the scoliotic deformity. This is the question which they have already asked. Next, the question which was asked, I suppose, in 2020 examination, you know, where they've asked about the screening test for the scoliotic deformity. In case of a school-going child, this screening test is the Adams screening test for the scoliosis in school kids, or Adam forward bending test, in order to know whether the scoliosis is structural or not, for structural scoliosis. All right. So this is a structural scoliosis. You see, if the patient is, for example, if any student is bending on his will, and when the same patient is asked to bend forward, then there is a normal curvature of the spine observed. So this is normal. But if there is another patient who is also a bent one, and when you ask a patient to lean forward, there is an abnormality or a bump which is seen, then it means there is a patient who is genuinely suffering from structural scoliosis. All right. So that is the answer for this question. Adam forward bending test is a screening test for scoliotic abnormality. Then the braces in scoliosis. You know, out of immobilizations, there are 2 points that you have to remember for the braces on scoliosis. Point number 1, what is the indication? If you are thinking that these braces will correct the deformity, it's a wrong statement. Indication is to prevent the progression of the deformity. All right. It is used to prevent the progression of the deformity. Braces and scoliosis are just used to limit the progression of the deformity. They cannot correct the deformity. Point number 2, what are the 2 braces which are used in case of scoliosis? The 2 braces are, one is the Milwaukee brace and the other one is the Boston brace. Now, Milwaukee brace is the CTLS brace. That means cervico-thoraco-lumbosacral brace. Every segment of the vertebral column is immobilized. The Boston brace is TLS brace. That means thoraco-lumbosacral brace only, where cervical column is not immobilized. Now you will say, what are the differences in between the two? The differences that you came to know. Cervical column is immobilized in Milwaukee, while the cervical column is not immobilized in case of Boston. Point number 2, then why are we using this? Or what is the indication where to use this Milwaukee and where to use this Boston brace? You see, if the apical vertebrae, now you cannot say that we don't know about apical vertebrae. If the apical vertebrae is T8 or above the level of T8, that means T7, T6, T4 or T8, all right, in that case, cervical column immobilization is the requirement. But if the apical vertebrae is below the level of T8, that means T9 or the above, like it is T9, lower segment of the dorsal column, T9, T10, T11, T12 or L1, L2, then in that case, cervical immobilization is not required. Hopefully you have understood that apical vertebrae is T9 or above, then it will be immobilized by Boston. If the apical vertebrae is T8 and above, then it will be immobilized by Milwaukee brace. So these are the indications for the use of the braces. All right. So hopefully everything is clear. Like ankylosing spondylitis in the spinal segment, we have already discussed in the integrated session. This is also a very important topic, but for INI-CET, they have asked this ankylosing spondylitis related question 2 times in the last 4 years. All right. All right. Next is the metabolic bone disorders. The next segment is metabolic bone disorders. And you know, the 2 questions they are asking persistently or repeatedly, one is related to osteoporosis and the second one is related to rickets. As far as osteoporosis x-rays, osteoporosis clinical features, osteoporosis lab findings are concerned, we have already talked about it. Important point to discuss over here is that what is the management for osteoporosis. All right, we are going to concentrate on the management related to the osteoporotic abnormality. You know, there are several conditions which might be provided to you. All of you know the first liners in the management of osteoporosis are the bisphosphonates. And there could be other conditions also, like other drugs also. But what if the examiner is providing you a specific condition and based on that condition you have to decide the management. Like in case we are talking about a post-menopausal osteoporosis, that means primary osteoporosis, with or without a fragility fracture. एक पेशेंट है आपके पास ऑस्टियोपोरोसिस का जिसमें कोई फ्रैक्चर नहीं है, एक दूसरा पेशेंट है ऑस्टियोपोरोसिस का जिसमें पैथोलॉजिकल फ्रैक्चर है, which is because of this osteoporosis. Management would differ. How the management is going to be different. Like if there is no prior fragility fractures, then the oral formulations of the bisphosphonates are considered to be the first line of drugs. Like alendronate, risedronate, zoledronic acid is the parenteral IV, denosumab is again subcutaneous, appropriate first liners. But you are having alternatives also like ibandronic acid, like raloxifene, these are considered to be the alternatives. But what about those patients where the patient is having a prior fragility fracture? Suppose the patient with osteoporosis comes to you और उसमें fracture भी है, then in that case denosumab and teriparatide along with zoledronic acid are considered to be the first liner drugs. That means parenteral drugs are the first line drugs. All right, denosumab, teriparatide, zoledronic acid are the first liners. Hopefully you have understood what I am trying to say. अब एक कंडीशन आती है जिसमें कि ग्लूकोकॉर्टिकॉइड इंड्यूस्ड, दैट मींस स्टेरॉइड इंड्यूस्ड ऑस्टियोपोरोसिस हो रहा है पेशेंट को, देन इन दैट केस instead of teriparatide, denosumab or any other selective estrogen receptor modulator, only the bisphosphonates are considered to be or are preferred over the management or for the management instead of using parathormone or these raloxifene and this denosumab. So hopefully you have understood. ये एक clinical scenarios हैं जो कि आपको दिए जा सकते हैं. Like if I give you a sample question and they have asked this question also like before, like 70-year-old female, उसका T score दिया less than 3. That means she is certainly a patient who is suffering from osteoporosis. लेकिन उसमें they have also mentioned that the patient is having a malunited Colles fracture. That the patient had a malunited Colles fracture. What is the first line management in that patient? So that means she is a osteoporotic patient with a prior fragility fracture. Calcium, vitamin D, yes, they are important, but these are not first line drugs. The first line drugs is going to be azolantonic acid. All right. So yes, specific questions are also expected to be asked in case of metabolic disorder like osteoporosis. As far as rickets is concerned, in integrated session we have talked about 2 to 3 different segments of rickets. But aapke liye from the orthopedic perspective, what is important is that calcium will always be provided as normal. All right. Vitamin D could be lowered. Values of vitamin D could be lowered. जबकि ये question में majority of the time they don't give it in the question. And yes, alkaline phosphatase is going to be higher. All right. If this is the condition provided to you, then answer for that question is nutritional deficiency ricket or vitamin D deficiency ricket. Simple. All right. This is vitamin D deficiency ricket. तो अगर कभी क्वेश्चन में आपको कैल्शियम नॉर्मल दिखाई देता है along with the alkaline phosphatase which is elevated, then don't rule out rickets. ये calcium is normal because you are measuring the calcium from blood, and calcium in the blood are regulated by parathormone, and because of hyperparathormone level or increased parathormone level, this calcium is mobilized from the bones into the circulation. So calcium level is maintained majority of the time in a patient or a person or a child who is suffering from rickets. So hopefully you get the overview like how the ricketic questions are going to be asked. उसमें alkaline phosphatase आपको मिलेगा, calcium level normal मिलेगा. Calcium level को normal देखकर don't rule it out. All right, because the calcium level is normal because of the parathormone. That is another important question. And yes, if they give you the X-ray of the wrist asking about metabolic disorder, possibly they are asking about the rickets. At this stage in this revision class, it will be too childish, like it will be too preliminary to discuss about what are the because we are expecting that you should be knowing about what are the features of the rickets on X-rays. All right, like there will be metaphyseal cupping, metaphyseal fraying, metaphyseal splaying, growth plate enlargement. So all these 3 features you should be aware of. Then one question out of eponymous fracture. They have asked this question related to match the following, and also likewise they have asked the question. Like this is something that you have to mug up. All right. Rest all the questions you can answer based upon your practice, based upon learning the subject. But this is something which you have to mug up in order to mark the correct answer. Although I have not compiled the entire eponymous fracture, it would be too lengthy, but yes, which are important, which are seen on day-to-day basis, which are very commonly seen or encountered in the practice. This is what we are trying to compile it. Barton's fracture. It is intra-articular fracture of the distal end of the radius. Simple. Smith fracture is exactly opposite to Colles, because in Colles there is a dorsal displacement distal radial. Here in case of Smith, there is a ventral displacement distal radial. All right, Colles fracture. Already you know about the Colles fracture. Yes, Bennett fracture is important. Like it is the intra-articular fracture base of the first metacarpal because of and along with the dislocation. Like what happens is, if this is the first metacarpal, all right, and this is the smaller segment over here. So this is the intra-articular fracture base of the first metacarpal. This entire metacarpal will be dislocated because of the flexor abductor pollicis muscle which is attached to it, but or the abductor pollicis muscle which is attached to it. But there are theories that it is this dislocation is not because of this muscle. Anyway, there is a dislocation which happens. So this is Bennett fracture dislocation, base of the first metacarpal, intra-articular fracture. Then Rolando fracture is comminuted fracture base of the first metacarpal. Simple. So intra-articular fracture base of first metacarpal is Bennett. If it is comminuted, if it is broken into multiple pieces, it is Rolando. Then boxer's fracture, fracture neck of fifth metacarpal. Mallet finger, inability to extend the distal interphalangeal joint. Jersey finger, inability to flex the distal interphalangeal joint. All right. Pop eye sign, you all know that if this is the biceps of the patient, then there will be a abnormal prominence of this biceps on flexion of the elbow. It happens in case of ruptured long head biceps tendon. If the biceps tendon is ruptured, all right, long head of the biceps tendon is ruptured, the entire biceps muscle get accumulated in the arm, and when you flex it, there will be a outpouching of this, there will be a abnormal prominence of this biceps bulk, which is known by the name of Popeye sign. Terrible elbow triad, this is something which is very importantly expected. Comminuted fracture of the radial head along with the fracture of the coronoid process with the dislocation of the elbow. Highly unstable kind of the fracture. Holster-Lewis fracture, the spiral fracture in the mid 1/3, somewhere in the distal half of the shaft of the humerus with associated radial nerve injury. This is Holster-Lewis. Schaffer's fracture, which is a fracture of the radial styloid. Then lower limb eponymous fractures like Gond fracture is the fracture of the tibial spine along with the anterior cruciate ligament injury. Terrible knee triad where there are ACL, they have asked this question, terrible knee triad also recently. Like ACL injury, there is medial meniscal injury and medial collateral ligament injury. All of them are injured in a single knee. Then it is considered to be terrible knee triad of or unhappy knee triad of O'Donoghue. All right. It is considered to be an unhappy knee triad of O'Donoghue. Then pylon or the plafond fracture is the intra-articular fracture of the distal end of the tibia. Runner fracture is the stress fracture of the distal end of the fibula. Then Pott's fracture is the bimalleolar fracture. All of you know that medial malleolus is the distal end of the tibia and the lateral malleolus is the distal end of the fibula. If there is a fracture in both of them around the ankle joint, it is Pott's fracture. Cotton's fracture is a trimalleolar fracture where there is an involvement of the posterior malleolus, and this posterior malleolus is also again a part of tibia. All right, it is not the part of the talar bone or the calcaneal bone. That is Cotton's fracture. Then March fracture, they have asked this question, March fracture again in 2021, I suppose, I don't remember it. March fracture is a stress fracture neck of second or third metatarsal. If second is there, that is the answer. If second is not there in the option, then go for third metatarsal. Aviator fracture is the fracture neck of talus, and lover's fracture is the fracture of the calcaneal bone. You know what is lover's fracture? If the patient is falling from height at the time of impact with the ground, there is a breakdown of this calcaneal bone. So it is known as the mechanism for this calcaneal fracture is fall from height. All right. One more you can write is Jones fracture, because it is again very commonly seen. Jones fracture. It is the avulsion fracture or avulsion of base of fifth metatarsal. It is the avulsion fracture base of fifth metatarsal, particularly in obese individual. If there is a history of injury related to supination of the foot, then this thing is very common. It is very common as a phenomena happens. Jones fracture, avulsion fracture base of fifth metatarsal. All right. Now they have asked the question out of soft tissue injuries around the knee joint. As far as ACL and PCL related injuries are concerned, we have already discussed it in the integrated session. Here we are going to talk about the meniscal injury. All of you are aware that there are two menisci in the knee, one on the medial side and the other one on the lateral side. Medial meniscal injury is far more common because it is very rigidly adhered to the capsule, to the medial collateral ligament. All right. Lateral meniscal injury is less common. Now, if you divide the medial meniscal into three parts, that means the inner 1/3, the middle 1/3, and the outer 1/3, then outer 1/3 is the most vascular part. The most vascular, it does not mean that it is having a vascularity. Most vascular is that it receives the majority of the nutrients through the diffusion process, the outer 1/3. The middle 1/3 is having an intermediate vascularity. All right, it has an intermediate vascularity, and the inner 1/3 is avascular. Sorry, this one. This inner 1/3 is avascular. That means it receives no nutrition through the process of diffusion. Now just imagine, if there is an injury to the inner 1/3 segment, there is no point of repairing it. All right, then in that case you have to perform a partial meniscectomy. But if there is an injury in the outer 2/3 region, yes, you can perform a repair of this. Arthroscopic repair is performed in order to expect a heal, or in order to expect the healing of this outer 2/3 of the menisci. All right, so this was your question. and the basis of that question was the vascularity. Like medial meniscal, highest chances of healing are there in the outer 1/3. So it will be in the outer 1/3 because it is considered to be the most vascular zone of the medial meniscal. And why is it being most vascular? It is also named as red zone. The middle zone is known as red and white zone, while the inner 1/3 is known as, the avascular zone is known as white zone. All right, so hopefully you have understood. Other than this, the ACL, PCL are very commonly asked question. Last year also, as I told you, that they have asked about the terrible triad of the knee, unhappy triad of the knee, the mechanism of action, everything we have already discussed in case of integrated sessions. All right, so hopefully you will go over there and learn about it. Now comes the most important topic. You want to know about the terrible triad of the knee. The terrible triad or unhappy triad of the knee is that when in a single knee, ACL, the medial collateral as well as medial meniscal, all of them are injured, then it will be a unhappy triad of the knee joint. All right. Now, the last segment for today, which is again very, very important, and for the last multiple years, like 2 to 3 years, we are saying continuously that is tarike ke questions are going to be more and more asked, where there will be an examination of the hip, examination of the spine, examination of elbow, shoulder. These are the kind of the questions. Because majority of your cases are going to be the hip joint cases, so examination of hip is considered to be the most important question for today. और इसमें जो entry segment questions है, entry level questions है, these are based on the Trendelenburg and the Thomas test. So what they are asking today is, before we talk about this question, let's have an overview, about the Trendelenburg test or Trendelenburg sign. You have to be very attentive, at least for this one, because what is Trendelenburg sign related? This is also a very important. Like repeatedly, we are saying that if you try to mug up and answer the question related to Trendelenburg, highest are the possibility that you might answer the wrong option. All right, or you might go with the wrong option. You just have to understand it. After having a basic understanding, you have to formulate your own answer. So Trendelenburg sign, before that, it is important to understand that what is the component of abductor mechanism. What are the components of the abductor mechanism of the hip joint? All right, components of the abductor mechanism of the hip. So there are two muscles, like one is gluteus medius and the other one is gluteus minimus. All right. Apart from this, there is a structure which is attached, means all these muscles are attached to the greater trochanter. Then from greater trochanter, they go all the way up to the intertrochanteric region. Then we have got the neck of femur, then head of femur, and the acetabulum. So together, they are responsible for the formation of the abductor mechanism of the hip joint. It means that imagine if these are the two muscles which are attached to the greater trochanter. All right. And this is the intertrochanteric zone, this is neck of femur, this is head of the femur, and this is rest of the femur. So this entire system is the abductor mechanism of the hip joint. Now what is the role of this abductor mechanism of the hip? Imagine when you are asking a patient to, or when you are standing on one foot, then the other edge or other side of your body has to be inclined towards the weight bearing foot, and that inclination is achieved by the pull which is provided by this abductor mechanism. That is the basis of this Trendelenburg test. All right. Again, I'm repeating my words, that if you are asking a patient to stand on one foot, all right, then the other side of the body, the hanging side of the body, has to get inclined towards the weight bearing limb, so that the center of mass does not go beyond the weight bearing side of the body. And that is achieved by the pulling force which is applied by the abductor mechanism of the hip joint, on which you are bearing weight, on which the patient is asked to bear weight. All right. So point number one is that the limb over which the patient is asked to bear weight, the abductor mechanism of that limb is on test. So that is the basis. This is the basic protocol of the Trendelenburg test. All right. So if you go back to the question which was asked, actually this is not for the first time they have asked this question. They have asked this question in JIPMER 2015 also. Like a patient is having a difficulty in walking upstairs. All right, this is the complaint with which he came. When he was made to bear weight on the right lower limb, the left-sided pelvis dropped. It's not that left-sided, there are no two pelvis, but the left side of the pelvis, it dropped down. All right. But when he was standing on the left lower limb, the right-sided, that means right side of the pelvis, it moved up. So before even we read about this question, first of all, we have to decide that what is the side which is affected. All right. So remember, when he was made to bear weight on the right lower limb, the left-sided dropped down. It means that the pathology is there on the right side. So abductor mechanism of the right side is affected. All right. And so what is the lesion? You are left with right-sided superior gluteal nerve option or the right-sided inferior gluteal nerve option. And you know that gluteus medius and gluteus minimus are the two muscles which are the components of the abductor mechanism of the hip joint, and they are supplied by superior gluteal nerve palsy. They are supplied by superior gluteal nerve. So answer for this question is right-sided superior gluteal nerve palsy. Hopefully you have understood how to go with these kind of the questions related to Trendelenburg test. One more thing that you have to remember, like in future, for example, if I give you this question, you know, for those who are interested in knowing it, that Trendelenburg test is positive in, like, all of the following condition, Trendelenburg is positive in, except if I give you this hypothetical question, that Trendelenburg test is a positivity in all of the following conditions, except options provided are malunited, IT fracture, that means intertrochanteric fracture, which is malunited obviously, then tuberculosis of the hip joint, then fracture neck of femur, or avascular necrosis of femoral head. All right. So these are the conditions provided, and now we are asking that in which of the following Trendelenburg test would be a possibility. Trendelenburg test is positive in all of the following except. So this is your question. So if you have mugged it up already, then you might go with any of the options. But remember, you know, this is the kind of the question which is preliminary. At least you are not prepared for this Trendelenburg at this point of time, so that you can answer this question or judge the importance of this question. But you know, the answer for this question, which is provided in majority of the books, is tuberculosis of the hip. But that is not the correct answer. The correct answer for this question is fracture neck of femur. Now just try to understand. The basic requirement for Trendelenburg test is that you have to make the patient bear weight on the affected limb. In case the patient is having a malunited IT fracture, yes, there is an abnormality in the abductor mechanism of the hip joint. You know, this region is affected. So Trendelenburg test could be a positivity. In case the patient is having a TB hip, based upon the osteoarthritis, based upon the shortening, based upon the involvement, yes, there is a possibility that TB hip Trendelenburg test could come positive, could come negative. In some of the cases, the condition is too painful where the patient cannot bear weight. But in case of fracture neck of femur, every time you go for Trendelenburg test, you will never ask a patient to bear weight where the patient is having an acute injury around the hip joint. So Trendelenburg test, performing a Trendelenburg test is not a possibility in this case. All right. So that is the answer for this question. Avascular necrosis head of the femur, obviously there could be a possibility that the patient could be having a Trendelenburg test positivity. So hopefully this point is clear. This is for your future. All right. Again, I'm saying that Trendelenburg test related questions, you just have to think and then you have to answer. There was a question which was asked in November 2021 related to Thomas test, that what are the steps to follow in case of Thomas test. Now, before we talk about it, just try to understand this. Imagine if the patient, this is a patient from the lateral side, we are visualizing the patient, is having a fixed flexion deformity of the hip joint. All right. The patient is having a fixed flexion deformity of the hip joint. So, would he be able to walk normally? Obviously not. So, he has to correct it by some compensatory method. He has to correct this flexion deformity by some compensatory method. So what is that compensatory method? By exaggeration of the lumbar lordosis. He will exaggerate the lumbar lordosis and will hide this flexion deformity of the hip joint. So this is known as exaggeration of the lumbar lordosis, which is compensatory exaggeration of lumbar lordosis. Then it will become a task for you as an examiner then how to identify this exaggerated lumbar lordosis. Then what you will do, you will make the patient lie supine on couch. All right. When you make the patient lie supine on couch, as you can see that there is an exaggerated lumbar lordosis, and you can place your hand behind it. You can appreciate that this is elevated above the couch. Now what you do, you will ask a patient, or by yourself you will do it, you will overflex the normal hip joint. By overflexing the normal hip joint, you are obliterating this exaggerated lumbar lordosis. You are correcting this exaggerated lumbar lordosis. The moment this exaggerated lumbar lordosis is corrected, the fixed flexion deformity on the hip will appear. All right. So this is what the reality of the Thomas test is. So what is Thomas test? Point number 1, it is to unmask the FFD of the hip joint. Unmask the fixed flexion deformity of the hip joint. How? By obliteration or correction of exaggerated lumbar lordosis. By the correction of the exaggerated lumbar lordosis, this fixed flexion deformity of the hip joint is getting unmasked. So this is what the Thomas test is. All right, be aware, be ready for these kind of the questions also. Then comes finally, means I don't know why, but this question has not been asked, but I don't know why we are expecting it. And if at all they are asking this question, it is going to be for the first time asked question. Now if you look at this x-ray, all right, now this is the level of the acetabulum, outer margin, and this is the level of the GT, greater trochanter, and you can appreciate the difference in between the two. On the other hand, here the level of the greater trochanter is higher in comparison to the level of the outer margin of the acetabulum. Now you tell me, the limb, that means the right lower limb, is going to be shortened or not? Yes, the right lower limb is a short limb. That is point number 1. Right lower limb is a short limb. Now this shortening, if you specify it, that where exactly this shortening is happening, is it happening proximal to the GT, is it happening in the shaft, is it happening in the leg, where exactly it is happening? So it is a supratrochanteric shortening. It is a supratrochanteric shortening above the level of the trochanter, supratrochanteric shortening. All right. Now what are the tests, clinical tests, which will diagnose this supratrochanteric shortening? This is what we are expecting. One is Shoemaker's line. Shoemaker line is a line in order to identify this supratrochanteric shortening. The second one is the Nelton's line. This is again a line to identify the supratrochanteric shortening. Then the third one is Sheen's parallelogram, all right, which is again to identify a supratrochanteric. How? Like Shoemaker's line, in Shoemaker's line, what you do, you join a line between ASIS and tip of the greater trochanter, and you project it onto the abdomen. If these two lines are intersecting exactly in the center, that means there is no problem. But if these two lines are intersecting on the other half of the abdomen below the level of umbilicus, that means there is just shortening on the affected side. Nelton's line is a line which is joined in between ASIS and ischial tuberosity. All right, in between the two, line joining ASIS and ischial. Sheen's parallelogram is a line, two lines are drawn, one in between the two ASIS and the other one in between the two greater trochanter. If the two lines are parallel to each other, it is normal. And finally, the test for stability of the hip joint. One of the tests that we have already discussed is the Trendelenburg test. These are the tests for the stability, assessment of the stability. Second test is SLR test. That means straight leg raising. If you ask a patient to raise the leg, all right, on himself, active SLR, it is normal, it is stable. And the third one is telescopy test. So hopefully we are expecting this question like Shoemaker, Nelton or Sheen's parallelogram. They will give at least one question, because examination of hip is something which is very, very commonly asked today. So I think this session might appear helpful to you. Here what we tried, we never went into a new sort of questions. The kind of the questions which are likely to be asked in your examination, we just framed those questions. And all the best for your examination, particularly this INI-CET in the recent one.